Well, welcome to the 10th in our series of COVID-19 podcasts. The topic of this podcast is living and working in India during COVID-19 and the effect of this pandemic on Black and minority ethnic communities. I'm so happy to be joined on my latest podcast by my colleague, Dr. Bhagteshwar Singh. I first got to know Bag when the Brain Infections Global study was put together, looking at brain infections in low to middle income countries. In our case, we were working in Malawi, India and Brazil, and Bag and I are both collaborators on the study. We've worked together so far in the UK, India several times and Malawi. Bag's currently based at Christian Medical College in Vellore in India, where he's working with Brain Infections Global, and he's also a clinical trainee in infectious diseases and general internal medicine in Liverpool in the United Kingdom. So thanks so much for joining me, Bag. How are you?
I'm very well, thank you, Ava. Quite busy, but that's kind of nice at times like this.
Well, look, let's start. Tell me a little bit about your background, Bag.
So I graduated as a medical doctor about 12 years ago in Manchester in the UK. And since then, I've focused on general medicine and infectious diseases training. And I'm about a year away from being a consultant in those specialties in Liverpool. About 2 years ago, I got this wonderful opportunity to be part of this brain infections group across Brazil, India, Malawi, and the UK that we're both part of. So that's what I've been doing full-time since 2018 as a researcher and a PhD student.
So look, tell me a little bit about Brain Infections Global, what the study is and why is it so important?
So this study is all about trying to make a diagnosis more quickly and accurately in people who come to hospital with possible brain infections. It can be really unclear initially when someone arrives at hospital, firstly, whether they actually have a brain infection, and secondly, what might be causing it. And that is really key in terms of working out how best to provide treatment to those people, how long to keep them in hospital, and potentially is the key then to reducing the amount of disability and the likelihood of death from what can be devastating conditions. And over years, we've realized that there is no magic bullet. You can't just send one test in and diagnose everyone, and that you need to look at different parts of the system within hospitals and the wider healthcare system to try and attack the problem from various angles. And that's exactly what we're trying to do in the Brain Infections Global Group in Brazil, India, and Malawi, but with a view to working out what might work beyond those countries in other low and middle income country settings.
Well, thanks for that. Look, you've been living and working in India throughout this pandemic. So turning firstly to that, I guess, how, in your opinion, is India coping with COVID-19?
So had you asked me this question back in March, to predict how well things would have gone, I think I would have said that India would have done really badly. There would have been by far the most deaths in any country in the world. Because although there have been improvements, India's public health infrastructure and especially public hospitals are struggling otherwise as well. And with the additional strain from the pandemic, I think everyone that I'd spoken to for advice as to whether to stay here in India or come back to the UK in March was that India would probably be hit quite badly, and it might be better for me to help the pandemic response there. And so, however, even though the actual number of cases has been massive now and has, almost just behind the US, I know India is, but it's almost the worst affected country in terms of number of cases. There haven't been so many deaths. And I think closing down early, stopping international travel, making sure everyone quite strictly adheres to a national lockdown very early on, I think bought India time in terms of increasing the number of tests that are available, in terms of working out processes for testing and tracing people who might have COVID or who might be in contact with people who do, and preparing hospitals for looking after patients who come there. So I think that has actually placed India in a better position in terms of tackling the pandemic. There have been criticisms about there not being enough preparation for the social and economic effects of a really strict lockdown back in March and April. And I think, and I saw those side effects, which obviously a lot of parts of the world have. And I think due to that, it had to be relaxed progressively. And since then, we have seen a rise in cases. Probably, hopefully we're past the first peak at least, but there have been lots of cases.
Yeah, I mean, you're right. I was reading that there's been over 8 million cases of COVID in India, with 121,000 deaths, which very much places it second to the US as one of the worst affected countries. But as you just pointed out there, it's got one of the lowest, what we call kind of case fatality rates. So, one of the lowest death rates, less than 2%. And so you think it's down to that early lockdown. Is that what you think as to why they've had less deaths than most other countries?
I think with percentages that were very different a few months ago, I think at that point it was definitely safe to say that there are probably a number of factors at play. I think as time goes on, I think we're realizing, for example, in the UK, there are more tests being done, and therefore we're picking up lots of people with more mild disease. That, in itself means that the case fatality ratio or rate comes down, as you see in epidemics. But I do wonder if there are still a number of factors. I don't think there's one answer. One of them could be that, if we're comparing with Western Europe and with the US, India has a lower average age of the population. And we know that there is this exponential increase in risk of dying from COVID as people get older, especially beyond the ages of 70 and 80. And the proportion of the population that are above those ages, it is in quite a lot of places that were hit badly earlier. So that's one thing. There's also other potential reasons for it, like increased awareness and people being more willing to get tests, and they're being more accessible. Potentially there are things that we don't know yet that might be different about the environment and about people, how they are in terms of their risk factors for severe disease as well, that haven't fully been explained yet or answered yet.
No, right. I mean, there's so much, this is one of the most extraordinary viruses, and there's so much that we don't know about it. And thankfully, so much research going on. You mentioned about the virus peaking. I read that it had peaked in September in India. Is that still the case?
Overall, I would say that's what it still looks like now. I guess that the problem with lumping all of the data from India together is that there are, it's a big country. It's almost as though it's like Europe, and the individual states are Europe, EU countries almost. So each state was. The very big cities, Mumbai, Delhi, Chennai, for example, were hit very early, and the states around them, probably had their peaks a few months before September. But as then COVID spread around the country, the total number of cases then seems to have peaked in September. But there are now some states which are lagging behind, so to speak, in terms of their waves of the pandemic. And so some of them are still at their peak. Here where I am, in Vellore, in Tamil Nadu, a southern state, it looks as though the peak was closer to August, September. And since then, there has been a decrease in numbers of new cases per day.
Right. So, I mean, I think, you make a very important point about what a huge country India is, and that there's lots of geographical variations across the country. I was also reading about India's pollution season, as it's called, where the air quality in Delhi and other cities deteriorates. The suggestion in what I was reading was that this could lead to a higher number of COVID cases and deaths. Do you have a perspective on that? What can you tell us?
As I understand it, pollution is air pollution and high levels of it predisposed to quite a few conditions now. It seems like every year we're finding out a new condition that is either more likely or more severe in areas with poor air pollution. I think lung health is something that it's long established that if you are in a place with high levels of air pollution, your lungs on average are not as good as if you're in a place with less pollution. So there is a lot of concern about this. And as you said, in this month really is the peak of air pollution. And we might not know how bad things will get until, next month, I guess. One of the things is that people with bad lungs who have long-standing lung disease are probably at a higher risk of COVID. So that's one concern. And then there's also the issue of, because air pollution potentially has wide-ranging effects, are people less able to combat new viruses or bacteria coming into their lungs or even their upper airways? Is there a wider effect on the body's ability to fight infection? There are all these concerns that aren't very well established, as you said, for COVID yet, which is as yet a very new disease.
Yeah. I mean, let's talk a little bit about vaccine. We're all hanging on to and praying for this miracle vaccine that's going to allow us all to get back to some kind of normality, hopefully. I understand that India could play a crucial role in a vaccine, but most importantly, not just in the development of a vaccine, but importantly, the distribution of any future vaccine. What can you tell us about that?
So there's lots of science going on in India anyway, but I think in terms of the COVID response, there has been a massive input from lots of different high-level institutions here. And that's meant that I think there are 3 vaccines currently in relatively late, so phase 2 or phase 3 trials that have been made by Indian scientists. And so, there's promise there within the country, but also Indian centers have collaborated with other places that are trialing the vaccine. So for example, the one that has been developed in the UK by Oxford University and AstraZeneca, there's a plan to trial that. And in fact, I'm not so up to date on it. They may have even started with sites here in India who are recruiting people to that trial. So there's a contribution to getting to a vaccine. But as you said, India is very well known for manufacturing pharmaceuticals, and that includes vaccines. And there are great success stories related to that, and related not just within India, but also supplying, for example, large numbers of polio vaccine and rabies vaccine and others to other parts of the world. So hopefully, leveraging that in India will be helpful for everyone.
Yeah, 100%. I mean, when I talk to people, as I said, we're all waiting for this miracle vaccine that's going to release us from this pandemic. But as much as, if we get a reliable vaccine, the problem is going to be, as you say, manufacturing it in sufficient quantities to inoculate everybody. That's going to be such a huge challenge. So it's really reassuring to hear that India could play, such an important role in that. But look, I wanted to talk to you in particular about the effect of COVID on Black and minority ethnic communities. In the UK, there was a report published recently where it said that people from Black and minority ethnic groups are more likely to test positive and die from COVID-19. And I wondered what your thoughts are about this. And probably the second part of my questions, that's the first part of my question. The second part is, why hasn't this been reflected in the Indian experience? So if you could just talk to me a little bit about that.
Sure. I've been following this quite closely. In fact, a couple of friends of mine have done a little bit of work in this area, and so I keep hearing about what's going on. And I think it's a complicated issue, as you'll probably know from the reports in the UK, from the Department of Health, for example, and other research, that the reason for people who are in Black and minority ethnic groups being more likely to contract or be diagnosed with COVID and more likely to die, it's not clear in every bit of research whether that is because of ethnicity itself, or because of other factors, or if maybe we can say now, with corroborative evidence from the US and from other places, maybe we can say that it is an independent risk factor to have, I guess, non-white ethnicity. Exactly what is leading to that is difficult to say, because there are higher, there's a sort of within people in the Black and minority ethnic group, you're more likely to have diabetes, for example, which in is itself a risk factor for severe COVID and death from COVID. Similarly, other chronic diseases of the cardiovascular system, heart disease, stroke, which can factor in. I guess maybe the fact that we're seeing lower case fatality ratios in countries where people are from, whether that's whether they've directly come from those countries, or whether there's second or third generation immigrant families. I think at the moment, on the face of it, it looks like there isn't a link in terms of the genetics per se of people coming from other places. But I think, unfortunately, that's not really been studied very much so far. And there have been some reports of a gene here and there that seems to give you a higher risk of severe COVID or death. Now, a lot of those studies have been quite small. They've not really been able to, say that with confidence. And there are more studies that are looking at those bits. But also, I think there's an opportunity here to say, well, what is it about people, for example, of an Indian background in the UK versus in India, about them in terms of, their other risk factors, so other illnesses, weight, or body mass index, BMI, and other factors that might, that we think are better established as risk factors for bad COVID. Maybe, looking at people from each country and comparing them head to head might answer some of these questions. Whereas at the moment, as I said before, that there are many reasons why India might not have the same percentage of people dying as we've seen in the UK and other parts of Europe. To tease the answer for this apart from those other factors, you'd probably need to have relatively similar people within each country and follow them up and see what happens to them. And thankfully, there has been a call put out by the UK Medical Research Council about this, or UK Research and Innovation about this, to try and get people to study this. And so hopefully there will be people from the UK and India, scientists who are trying to answer this question within the coming months.
Yeah. I mean, is there anything that can be done to remedy this increased risk for the more vulnerable ethnic groups around the world? Is there anything that people can I guess, do a quick fix? I mean, is it more of a lifestyle or cultural change that's needed among different groups, or both?
So I think what we've found out so far in the last several months is probably what we need to stick to. So, for example, if you think about people on an individual level, focusing on what what there is about me, for example, that makes me at a higher risk, and then looking at what might be something that I can tackle, is, I guess, what I think most people have been advising so far. So for example, I perhaps don't eat as healthily as I should, and maybe don't get enough exercise, and we know that higher body mass index and just general poor health are risk factors for not doing very well if you get COVID. So my focus then, has been, continues to be, and should be on working on those factors that are in my control. I think until we work out exactly what it is that is responsible for the BAME population being at a higher risk, I think rather than addressing those communities as a whole without, with making assumptions and without really knowing what is driving the problem, I think could risk maybe even alienation, and it could be quite controversial to say, well, you're at higher risk, therefore you must have more strict measures in place, as I think has been discussed in the last few months regarding shielding for everyone over a certain age in the UK. I think making blanket rules like that can be quite challenging, and can it is almost definitely likely to then be seen as unfair by certain people within those sections of the population who perhaps for some reasons are not actually at a high risk themselves. They're just hit by the additional restrictions.
Yeah, I mean, it's a good point, isn't it? I think there's a lot of controversy at the moment about individual liberties, kind of blanket restrictions, as you talk about it, conflicting with people's individual liberties and their right to choose. But anyway, I'm sure that's another podcast. Do you think that there's enough research ongoing around the world looking at the issues experienced by Black and minority ethnic groups?
So I think that ever since, I guess it was probably April or May, that there were these signals coming out, thanks to really big studies that are happening already, like the ISARIC study in the UK that's got over, I think, 80,000 patients already from hospitals in the UK. But similar big studies in other places have been either set up, or they've people have gone back and tried to look at this question within single countries. I haven't seen much that has tried to look at this question in multiple countries at the same time. There have been attempts at trying to pull all of those different studies from different countries together and try and come up with an answer, with some interesting results that suggest that ethnicity probably is a risk factor independent of other things. That was published in one of the Lancet journals a couple of months ago. But I'm really happy, as I mentioned earlier, to see this call from the UK Research and Innovation guys for research that actually is based in both countries at the same, or in two countries at the same time, recruiting people of the same ethnicity and doing a head-to-head study. So had you asked me a month ago, I would have said I really think these sorts of studies need to be done. Apologies if they're already being done and I'm not aware of that, but I now am aware, and I'm happy that that's the case.
Yeah. Oh, well, that's reassuring to hear. Well, we're coming toward, I guess, the end of our time together on this podcast, but a couple of questions, I guess, from me before you go. What do you think the lasting legacy of this pandemic will be for the world and for Bhagteshwar? What's, difficult question, but what do you think you've learned and that you'll carry with you for the rest of your life, and what do you think we as a world we will learn or should learn? Although I think as the human condition, we're notoriously bad at not learning from bad things that happen to us. But what are your thoughts?
Yeah, thanks for that question, Ava. I'm there are so many things I think that I've learned personally, and that I think globally we've learned over the last several months. I think. Can I give you two answers? One that is perhaps more focused on research, just because that's sort of what I know better at the moment, and one that's a bit more general. I think firstly, I'd like to say that learning that learning from the first wave to feed into the second, I think has been really important, and on the similar, learning from other countries how things have been done. Nowadays there's so much transparency, I guess, in most countries about what is happening. We have the unique opportunity to see what happens in other places and then draw from that and try and tailor it to our local setting. And I think there's been a lot of learning between countries throughout the last several months. And I think that, not going into detail, I think some people have pointed fingers at some places that haven't seemed to do that very well. And I think then have, potentially been in a worse situation because of it. So I think, collaborative working between countries and between different people with different expertise. There's been so many great examples of that throughout the world that I've seen, and I've learnt how that actually works, rather than seeing it from the outside as something that seems like a good idea. I've been had the opportunity to be part of that. So in terms of research, for example, our Brain Infections Global Group has initially we had to stop the study because it just wasn't a priority at that point, and it might even have been dangerous for us to continue doing things not knowing what the virus was like at that point. But rather than just sort of going and doing different things, we thought, hey, we've got this big team of people who know each other very well, work with each other very well. So we repurposed or turned our expertise and our team to COVID. And so on the back of that, we set up a COVID Neuro resource, COVID Neuro webinars, which try and keep people in touch with what's going on in terms of neurological problems, which is what we've been focusing on anyway in Brain Infections Global, and how COVID is potentially related to quite a few of those. And then we've even been able to set up a study, which hopefully will be starting very soon, to try and find out who is at risk of developing a neurological problem with their COVID illness. So it's been great to be part of that, and a couple of other such ventures within research here at the Christian Medical College and in other parts of South India, but also I guess having the opportunity to be seconded to the WHO Southeast Asia Regional Office, which is based in Delhi here in India. But by the time I joined, there was a lockdown imminently coming in. So I stayed in Vellore, and I've been supporting remotely since then. And that again has taught me loads about how we can work together between countries to try and prepare for what's coming. And I think we're seeing the benefits of that now, even though with it feeling so bad, it's sometimes difficult to see that through all the badness. I think if we reflect, we've come a long way since January and February.
Yeah, so the power of collaboration, the notion of being stronger together, all of those things is so important, isn't it? I don't know if people can hear this on the podcast, but that's my recycling being picked up. If you can hear strange noises, this is what happens on our podcast. We usually get my dog barking at some point, but well, look, as we bring the podcast to a close, is there anything else that you'd like to say, Bag?
Not really, but just except for thank you very much for having me on this, Ava. And I look forward to us continuing to work together and doing our little bit to help in the fight against COVID, as well as the broader Brain Infections Global project.
Yeah, I look forward to it as well. I think weren't we meant to be in Brazil together this month? And we're doing our Brazil meeting via Zoom over 2 days. Yeah, I can't bear it, right? We should be in Brazil.
I know. That's one thing we're learning as well, right? How to do things remotely, and try not to be upset that we're not on the beach. Sorry, near the beach.
I don't think Professor Solomon had let us be on the beach for very long. That's my experience anyway.
No, true.
Well, look, we've covered an awful lot. We're so grateful to you for taking the time to chat with us today, Bag. Just to reassure everybody that the Encephalitis Society services remain unaffected. So if you need any support or information, our teams are still at your service. Go to encephalitis.info for contact details or to chat online. And as always, if you can support our work at this very challenging time, then please visit encephalitis.info/donate. But most of all, from Bag and I, wash your hands, keep your distance, and stay safe, everyone.